Infectious diseases don't stand still. Research has led to extraordinary advances, but the gains aren't felt equally. Antimicrobial resistance is eroding our ability to treat infections we once considered manageable. HIV and hepatitis C are escalating in our region. Sexually transmissible infections are rising. These challenges demand rigorous science, powerful partnerships, and systems that reach everyone.
We've made lots of progress in areas, but now we need to ensure that that's reaching everyone.
It's really important that we look across the health system to understand how to implement infectious diseases interventions and to enable their scale up so that everyone has access to these new interventions.
We know that we need to come up with new ideas about how we engage Aboriginal people in health services. We've implemented a new program at the Kirby around co-design with our Aboriginal communities to implement our research projects.
There is still so much about viruses that we don't understand, and that's something we're really working towards in the lab. It's to build that foundation so we can work on that path to develop a cure.
So collaboration in our research is a core feature of what we do.
We need to understand the needs of the communities that we're working with to make sure that we can design responses that are going to be effective.
I think research is really important for addressing these priorities because it gives the evidence base. It ensures that policy and program and investment is evidence driven, and that's really crucial at the moment.
The Kirby came about from a real sense of crisis in the 1980s when AIDS came to Sydney, and it was community connected right from the beginning.
It was a need for evidence to respond to HIV. It was communities, academics and clinicians coming together. I think the early values that continue to shape the work that the Kirby Institute does is that of collaboration and of letting community shape and drive priorities. So I think the Kirby Institute is important into the future because it has the skills and the breadth of experience to address the challenges that we see here in Australia and in the region.
Now, these things don't magically appear. It needs a lot of hard work, and we can't do it without partners.
So it's really important that the Kirby works in the region because we've had a lot of success in Australia, and those include things like working with community, partnership with the right kinds of stakeholders, and doing really genuinely engaged work that's listening and learning from the communities that we work with.
And then it's our ability to take that expertise, passion, and those solutions that we develop back into the community and apply those.
What we'd like to see here is that no one gets left behind, and a part of that for us means bringing a functional cure to the general public who would need it the most.
We need to be innovative. We need to be thinking about new ways of delivering healthcare services. The challenges aren't getting any easier, and we need to be working collaboratively to help find solutions.
It takes partnerships.
It takes dedication.
It takes creativity. It takes a sense of humour.
It takes careful listening.
It takes persistence.
It takes working together.
There's so much more to do. We're just getting started.
It's going to be showing at the Cannes Film Festival next year. So, John Calder, that's me. I've been at the Kirby Institute for actually almost half my life, which is quite a frightening thought. But I'd like to start off by acknowledging traditional owners in this part of our land, Aboriginal people, and extend that a welcome to all Aboriginal and Torres Strait Islander people who may be joining us today and online, and recognise all the other traditional owners in different places where you're joining us from. This is a special event that is part of our 40th anniversary year. It really is 40 years since the Kirby Institute, previously known as, once known as the National Centre in HIV Epidemiology and Clinical Research, was founded in 1986. We became the Kirby Institute about 15 years ago, and it's very nice to welcome Michael Kirby, our patron at the front here, and also to acknowledge many very distinguished people who we've worked with for many years, some of whom are going to be joining us on panels and speaking to you later on. And we have our Deputy Vice-Chancellor, Vernon Crossley, and a number of other people who've come along today. I'm sure others will. I believe Peter Bohm, one of our Life Governors, will also be joining us. And I think Peter's just held up somewhere. So hepatitis C is probably the thing we're almost as well known as HIV, but I'd like to just briefly remind you that we're also known for many other infectious diseases that we've been working on apart from those, but it's clearly hepatitis C that has stood apart in one very significant way. It's a virus that was both discovered and conquered, if I can say that, during the period of the existence of the Kirby Institute, and we played our part, and that's what you're going to hear about today. In fact, I feel a certain affinity to the hepatitis C virus because it was discovered around about exactly the same time that I started at the Kirby Institute. I remember I was very new to infectious diseases. I was just back in Australia after having been overseas for 11 years, and I was just learning about HIV. I was very much a newcomer, and as I was trying to understand what HIV was all about, one of my people who became a very close colleague, Nick Croft, said, "What about hepatitis C? Haven't you heard about that?" And I actually hadn't, but I quickly found out what there was to find out, because it hadn't existed. Well, it had existed, but it hadn't been known. It was the virus that was causing a thing called non-A, non-B hepatitis that was a long-standing mystery. And in 2020, the discoverers of hepatitis C actually were awarded the Nobel Prize very appropriately. But what happened after that was a series of activities that we'll hear about from our speakers and panelists, which led to both amazing advances in prevention and amazing advances in treatment related to hepatitis C, to the point where we actually can look at the future without hepatitis C, because we can both prevent it very effectively and we can cure it very effectively with the drugs that we have. One thing we still don't have is a vaccine, but that's for another time. This is a symposium today to bring some of that history together. This was happening in what we think of as perhaps the second decade of the Kirby Institute. We had the first decade when 1986 we were formed, and by 1996, the year that combination antiretroviral therapy came along, we were already the world was turning the corner for HIV, at least in countries that could afford the therapies by 1996. But we were confronting this new virus, or this relatively new virus, and trying to figure out both how to do that prevention and treatment that you'll hear about more today. So it's a really an important story that goes from the start to the finish, and really gives insights into all of those principles that were expressed by how we work in the short video that is one of the new products of our fantastic comms team. So the way that today is going to work is that I will be introducing our keynote speaker in a second, and then hand over to Carla Treloar, who's going to introduce a panel of some of my very esteemed and illustrious colleagues with whom I've learned so much from over many years and worked very closely with. And then we will have probably a bit of will there be a Q&A? We'll do a bit of Q&A after that. So we'll have some opportunity for the audience to participate. And then we will just go on our merry ways. So our keynote speaker, still working on a talk over there. So Kerry Chant, I remember the first time Kerry walked into my office, which was more than 30 years ago, with a tantalizing problem, which was that there'd been a discovery that some people who you wouldn't expect of those era to have HIV, there was very much an era where there was a mindset, the only way you could catch HIV was if you're a gay man. Of course, that's not true in many other parts of the world, but it was very much the view in Sydney at that time. It turned out that there were cases of HIV popping up in unexpected individuals. And it also turned out that a common factor of those individuals was that they'd all had day surgery at a clinic, which is just on High Street, just here, just where we are. And Kerry, as a young public health officer, Kerry Chant, had been given the task of disentangling this problem and trying to figure it out. Now, we all know that Kerry went on to great things and is now the longest serving Chief Health Officer of New South Wales, and Those who didn't know her before the COVID-19 pandemic certainly knew her very well through that pandemic, and Kerry guided us, or Kerry guided the political and political side of New South Wales, and to a large extent the country, through that very difficult era, and of course has been responsible for many other important successes and achievements in public health for New South Wales and Australia in general. So Kerry is, I think, probably doesn't need too much introduction, but has a very strong background in communicable disease control. And one thing that I've always, when Kerry, when we first met, she produced a couple of really crucial publications around that HIV outbreak that I mentioned, but also a number of other activities. And I think a number of us thought that Kerry could be somehow lured into the world of research, but she stayed steadfast in her mission as a public health leader. But what has really characterised Kerry's approach as a public health leader is her ability to work very closely with research, and she's been an absolutely key partner to the Kirby Institute and many other research groups in both encouraging us and stimulating us and challenging us and making sure that our research is entirely relevant, but also really strongly supporting our research and making sure that that the government is able to fund it and in different ways, and to respond to the work that has been the outputs of that research in the most effective way possible. So it's a great pleasure to introduce Kerry as our keynote speaker for today. Thank you, Kerry.
Thanks very much, John, for those kind words. And good afternoon, everyone. And thank you for having me here to celebrate the amazing 40th year anniversary of the Kirby Institute. I'd like to acknowledge the traditional owners of the land on which we're meeting, the Bidjigal lands of the Eora Nation, and pay my respects to elders past, present, and emerging. And I also want to extend my appreciation to and respect to any Aboriginal and Torres Strait Islander people joining us today. I'd also like to acknowledge people with living and lived experience of hepatitis C, and just express how critical they've been in shaping the response, and how critical, even more important, they are if we're going to continue to drive us to virtual elimination. So I was asked to give this and incorporate some of my personal reflections. So apologies if I'm going to wander, because it has taken a bit of time to just reflect on the journey with hepatitis C and what I was thinking about and what are some of the issues that happened. And as you know, your memories are fragmented. And so when you're trying to put yourself back in those times, you sort of have vignettes. So please apologies. But I think it's really important that we remember where we've been so that we can chart the journey forward. So 40 years is a long time. And when I remember my first involvements with hepatitis C, I was asked quickly after the HIV investigation to investigate a transmission in a healthcare setting. And for me, that meant that I had to rapidly understand about this virus. You know, when you think about it, what proportion of people are asymptomatic, how many have acute diseases. So it was really formative in some of the work that the Kirby, our researchers did, but internationally, how we understood what the natural history of this disease that was really relatively well known. One of the other interesting dimensions was just how the Kirby has really strengthened our understanding of the epidemiology. I can remember reading tomes about our view of the epi compared to a CDC's view of how it was spread, and they were poles apart. So I just want to say that non-political, non-judgmental way in which we've gone around public health in Australia has to be a thing of the future. So probably I don't need to tell people in the room, but there was certainly more of an overemphasis on sexual transmission because of the stigma and discrimination. And it is how you ask questions in epidemiology. If you ask questions in a loaded environment, ask questions in a loaded way, or there are perversities from answering questions in particular ways. And that's one of the great strengths of the healthcare system in Australia, where I think, you know, free access to healthcare, and yes, we have stigma and discrimination, but it's not at the levels and the financial barriers are not there in the same way they are in some other health systems internationally. And we have to be incredibly proud of that. I would also just like to sort of acknowledge that New South Wales, and this is a credit to people that came before me or around the time, really worked in partnership with the Kirby around generating the evidence around needle syringe programs. And yes, we had that from HIV, but I think the scaling up of that at that time and the willingness of the department to really embrace evidence around NSP was really very critically important. I would also just like to sort of reflect that the next sort of shapings of me with hepatitis C was I was working in southwestern Sydney as the director of the public health unit there. And if anyone's familiar with that time there was significant issues with opioid use, street-based injecting was rampant, and there was a lot of visible drug use. Lisa Ma, and I'm not sure if Lisa's in the audience, or I just want to say that working with Lisa Ma was an absolute privilege, and the peer workers. It was amazing. And we set up an incident cohorts study looking at seroconversion because we're trying to understand about what were the prevention methods and what the role that needle syringe programs would put into it. And there was always the debate about, remember the debate about the spoons, the water, which things, the tourniquets, and what was the relative contribution of various things in explaining it. But I think from that study, what we learned was if you're street-based injecting in a pressured environment, there is no way that you can protect totally from the transmission risk associated with hepatitis C. It's much more infectious for HIV, and the pool of infection in the population was already there. So your chances of sharing or coming in contact with someone else's blood, the ability to keep it off your fingers or off objects was just impossible, particularly in that more chaotic street-based injecting scene where you were very pressured to do that. I had the privilege to learn a lot about as a public health, early public health physician, around learning about the context of injecting and how everyone's different story is different. And for me, some of the learnings around the gender disparity and sometimes the pressures on women to share, and how to not do so was not seen as almost a rejection. And some of the, for me, the cultural context for injecting and how prevention initiatives had to really be cognizant of that. I know this comes naturally to you, Carla, but for me, it was a really important part of my journey to also have that thirst for understanding the context. And that meant that also not all people with hepatitis C or injecting drug users were going to embrace the same intervention. So again, it gave me that layered nuance that we would have our street-based injectors, and there would need to be a much more intensive intervention, a different intervention than perhaps the more stable, longer-term injectors. And that when we're designing our programs, we have to actually think about where's the incidents being generated to break that transmission cycle. And so you could invest, but if you're only touching low-risk injecting drug users for the purposes of hep C transmission. I think also was interesting for me was experiencing how even our clinicians experienced different realities with hepatitis C depending on the patient cohorts they saw. And I think part of the importance of us coming together in southwestern Sydney is bringing the different perspectives, because we know our cultural linguistically diverse communities, often through perhaps by injecting drug use, but in some of it was medically acquired from their homeland. But different people had different experiences, and it was really important to have a shared experience or not dismiss someone's cohort or experience based on what you're seeing in your clinic. And I think that's one of the other things that I think the Kirby has done well, is engage in a discussion of the data in totality rather than the anecdote about our personal experience, even though I'm sharing them all now. So look, our partnership with the Kirby has been a really strong one. And I think it is a strength. I think I've said this before in an HIV symposium, that this works best when we've got really strong capabilities within ministries of health or policy domains, really strong academic partners, and then really strong NGO sectors, be it newer or other groups. It is really critical because how we shape the future has to blend all those perspectives. I'm not going to be able to guarantee sustained funding for something that isn't cost effective, sustainable, that's got a workforce, and that I've got a regulatory framework to be able to do. Yes, I can change regulatory frameworks, but I need to have some of that evidence underpinning it. I think we've done some really great work with the Kirby on testing models. But again, that's a classic example where we've gone for agreed to come with the mantra of right test in the right place at the right time, and really dissecting when, for our purposes, it's actually good to have a full blood, like a full blood draw, when it's appropriate to use point of care testing, when it's appropriate to do our dry blood spot testing. I think one of the things that's also useful is that every health system is unique, and even across the nation, every health system is unique. So in our design of our health system, we're probably a little bit similar to Queensland, but we have different infrastructure and capabilities. So for now, I know this sounds a long time away, but by 2028, we will have a single digital patient record in New South Wales. We are also moving to a single laboratory information management system. And I know Bill's in the room. You can sort of say you've seen it before you retire that we do this, but people don't understand how important that is to make data linkage more efficient, to make sure we can have seamless follow-up tests. We're having discussions around what our SHIL service that we're funded in southeastern Sydney does to make sure that as we're ramping up dry blood spot testing, so that everyone in prison entering the prison system has a dry blood spot test on intake, that we've got the ability that, given many of them are on remand and only spend a very short period, that we've then got a service that can seamlessly pick that up. And because Justice Health is on the same data system, our laboratory system will be visible, then we can actually get our SHIL service as a statewide service to pick those up. So again, for the researchers, it's really critical that even going forward to the next level, you understand some of the service enablements we've got, and even to pitch your research to look at this, because sort of the challenges for us is what's the effective intervention when we're discharging patients from Justice that haven't managed to get their antiretrovirals. I mean, Chris, we're just having a discussion a couple of days ago about what is the barrier for us not holding our starter pack in our Justice facilities, and what, poisons legislation we have to change, or regulation, or is it about cost, or is it about someone prescribing it? What is the barrier? So there's often these very practical issues that impede us doing the work we need. And by partnering with us, we can't always solve it, but we can start with, let's give it a genuine shot. And I just want to acknowledge the painful journey that Chris has had in trying to get reflex hep C testing. Can everyone really advocate for that, please, and keep whinging? I think we're on the trajectory of bringing that to fruition, but we do need loud voices around how important that is. I also just want to acknowledge where we've come with treatments. And again, I had the privilege in southwestern Sydney in the public health unit. We had a hepatitis C nurses, and the most dedicated nurses that you could ever ask for. And I remember them, supporting patients through the interferon-based therapies. And that was really, really tough. And I think even remembering when we did one of the, look backs, some people really regretted us even telling them that they had hep C. They felt so hopeless about the treatment trajectory, so uncertain about what it meant for health. Where have we got to now? It's just amazing. The tools we've got available, the drugs and the side effect profile of those drugs has really enabled us to shift from a very highly specialised, highly supportive to much more at scale. But the challenge for us is the social factors we're going to have to wrap around our very marginalised groups that we're now getting to that have missed out on treatment. We have always done well in our Justice Health Service, and I think that's been a strength of having a New South Wales Health-led Justice Health. And the treatment levels in our justice health service is incredibly grey, but it's the ones that as we scale our testing and get everyone tested, how do we get those ones that are on remand that'll go out very quickly connected to care, give them the therapy and make sure that we've got them completing the therapy. The final thing I'd just like to reflect on is that stigma and discrimination has been a key theme. And in southwestern Sydney, we had to deal with hepatitis B as well. Fairfield, I think, rates as the highest proportion positivity of Hep B. Greg, has it changed? Roughly. Let's not fight over the claim for the first LGAFI. But I remember also the pivotal work that we've done with primary care, and that's probably something to always remember. Primary care is at the coalface, and I think that was also a very privileged moment to work with the general practitioners around enabling them to provide better care and support them in ways that made sense for their patients, and connect with our clinicians. In retrospect, I think we transitioned pretty quickly from very super specialised models for those patients that needed it. But I just want to say that that was a bit of a tussle all around to free up models of care. And I suppose next time round, I challenge ourselves to always think about who is best placed to initiate treatment. How can we support the complexity in a seamless way? How can we use our virtual and digital enabled services, particularly to address some of the inequities of access? We know that for our complex patients even, we've got to do some work in the state to make sure they're better supported and models of care. So overall, I'm optimistic highly, but there's a lot of hard work, and it's always harder the last bit. So we've got to all use 2026 into 2027 to reinvigorate the invigorated response and really do everything we can to get people more rapidly on treatment. Because if we can start driving down the positivity, that's critical. We are dealing with some interesting dilemmas, just to put out there in policy land, around peptide use in our needle syringe program. So we're having some really challenging discussions around what is the purpose and intent of our needle syringe program. How do we ensure that it's available for those people that don't have means to procure, say, clean injecting equipment, because we do have to consider the pie. You know, there is a limited budget and we want to spend it on, have the best mix of services, but we may need to grow it if that's the response. But just saying, we are working with that. So again, another piece of work that I think I'd put over to you, and I know that some of you have been involved in some workshops with the ministry to sort of discuss what our approach to that is. But that's certainly causing some concern, because whole swags of our vending machines are being emptied, and therefore when someone's going to use them, there is no clean injecting equipment, and they may not have an alternate method. So it's a really interesting issue about how do we do that in a way that doesn't have perverse things. So just as a flag, I will be knocking on your door and we will be asking you to help us as we navigate this next policy dilemma. So thank you very much to the Kirby. It's genuinely been a privilege to work with you. And I just want to thank everyone that's associated with the Kirby, because you've also stepped up and provided advice at all times. You know, in recent times, just want to acknowledge the contribution of the Kirby in responding to the MPOX, and, you know, the willingness to come together. Our collective heads are always better. And so everyone's got something to contribute. And I think the strength of New South Wales is in its whole and entirety. And that's one of the greatest privileges of this role. The fact that I can pick up the phone, and most of you, except John, when you're over in Cambodia or Europe, usually in Europe, John. Let's be frank. It's usually Europe. Sorry, or Byron. Yeah, or Byron. It's always a great privilege of this role that people tend to answer the phone when I ring, but it's usually because I really need that rapid advice, and I really respect the expertise around me. So thank you for your great graciousness in answering that phone. Please continue to do so. Thank you.
Hello, I'm Carla Treloar. I acknowledge the traditional custodians of these lands, the Bidjigal people, and I'm really honoured to continue the many, many thousands of years of teaching, learning and sharing knowledge that have happened on these lands. So I am not from the Kirby Institute, and I'm from this little place now called the Centre for Social Research and Health, just down the hill on UNSW campus. And our centre is 4 years younger than the Kirby Institute, and we were founded as the National Centre in HIV Social Research. And I joined that centre in 2001, having landed from Imperial College London, where I was working on Bangladeshi public health. But I just happened to be in the same unit as Jerry Stimpson, Tim Rhodes, Matthew Hickman, who were some of the forerunners of the UK response to hepatitis C. And when I came here to work for 2 years, 25 years later, for 2 years on an NHMRC-funded project about blood and hepatitis C that was awarded to Sue Kipax and colleagues, I started to realise, oh my gosh, there's a lot of knowledge here, right just up the hill. Well, actually, not just up the hill, in Darlinghurst. And I remember going over to see Greg in that terrible office next to St Vincent's, having to kind of shuffle between boxes of papers stacked on every wall and go, what is it that you do? And can we work together? And that has been a tremendous experience for me and the rest of our centre. So I just looked at my CV last night, and the Kirby Institute litters my CV. So there's 45 publications with Greg on there, 68 with Jason Grebley, another dozen or more with Lisa Ma. And one of my first big grants was led by Andrew Lloyd from a UNSW strategic initiative on hepatitis C vaccines. So it has been an amazing 25 years working with the Kirby Institute, but more so in the whole social policy, community, health worker ecology of hepatitis C. And every day I get to work with and speak with the most amazing people who have insights from their lived and living experience, from people who've been working in the trenches in various parts of the health system, people who are making policy. It's like no other job I've ever had, though this one has been a very long job. And it's sort of what burns the fire in all of our bellies, I think, is to be able to work and learn from amazing people every day. And something new comes across the desk every single day that stretches our thinking, adds our commitment to this work. So I've had the absolute pleasure and honour of forming very deep and long-lasting bonds with the Kirby Institute, even though I'm not from here, but I always get mistaken as if, you know, the Kirby Institute is the only place in UNSW that does anything on Hep C or anything else. Oh, you're from the Kirby Institute. And, well, actually, no, I'm not. And I'm sure I'm not the only one who has that experience outside of here. So it's my pleasure to run this panel today. So I'll ask Kerry to join, but I'm going to introduce everyone else as well. And for people in the room and online, there's a Slido connection to ask questions. There's a couple of QR codes on the screen and on the walls for people in the room, and it's also on your screens if you're watching online. So as well as Kerry, we're joined today by Sione Crawford, and Sione is the CEO of Harm Reduction Victoria, the organisation representing people who inject drugs in Victoria. And again, Sione and I have worked for a very long time when he was at NUA, the New South Wales Users and AIDS Association, also a very long-standing community organisation. Greg Dorr, could you please join the panel? Greg's the head of the viral hepatitis clinical research program here and an infectious diseases physician at St Vincent's Hospital in Sydney. Alex Thompson, director of the Department of Gastroenterology at St Vincent's, Melbourne, and also from the University of Melbourne. and Ingrid Van Beek, public health and addiction medicine physician, long-standing director of the Kirkton Road Centre and founding medical director of Sydney's medically supervised injecting centre. Coming off the bat of, as Kerry described, we kind of knew something was happening, particularly in the 90s, but surveillance was very young. Real infections were undercounted. The available treatment was awful and brutal. But when did it become a public health issue in your mind? Ingrid, do you want to start? We'll move down the line.
Hello. Yeah, as mentioned before, hepatitis. We were aware more generally of non-A, non-B hepatitis, but it wasn't until it got its own letter that we really started taking it seriously. And I guess that was when testing became available in about 1990. So yeah, I'm reminded of Donald Rumsfeld's saying, "You don't know." You don't know what you don't know. And so yeah, we were also like going along, very focused obviously on HIV at that stage. And so it really wasn't until that testing became available that the sort of light switched on. And for me personally, as a public health physician, that was a really important lesson, not just to focus on what has a letter, what has a test, but to be thinking about what might be out there that we don't know about. Like with COVID, to think that that was the last pandemic that we'll ever be affected by would be naive and optimistic in the extreme. And so Hep C, that experience with Hep C was very, very enlightening from that point of view. And of course, yes, we discovered that at Kirkton Road Centre, where we were seeing a lot of street-based people who were injecting unsafely, we found ourselves in the heart of it.
Yeah, thanks. Alex, over to you.
Thank you. So I finished my medical degree in 97, was a gastroenterology resident in 98, which was my first exposure to hepatitis C, and I think it was well known that it was a public health challenge at that time. But my reflection would be that we did not use treatment as a public health solution to the hepatitis C problem at that stage. We did a lot of work in terms of trying to optimise the dose of interferon, a very toxic treatment, the optimal duration, identifying personalised markers of treatment response. And there were lots of clinical trials, and Greg played a very prominent part in many of these. And that was a very exciting time for a budding clinician researcher. But really, we were just scratching the surface of the public health problem that is hepatitis C. One thing that I'd really acknowledge the Kirby for was proving that it's feasible to treat people who inject drugs, even with a toxic treatment like interferon, and the treatment could occur in the community. And I think that really laid the foundation for the subsequent use of treatment.
We're going to jump into that later on, Greg.
Well, I joined the Kirby in 95 and certainly joined not to do Hep C work. I mean, I remember David Cooper having a corridor chat to me in Yokohama at the World AIDS Conference in 94 and saying, I want you to be my man in Asia, and to do some HIV work in Asia in terms of some epidemiology and other work. So I sort of joined in 95, did do a little bit of work in Asia, but got involved in Hep C really through sort of John's sort of work around surveillance and epi. And I was sort of reflecting on where we'd come from and looking through my CV. And I think my second sort of paper on Hep C was, in fact, based on a cohort study at Kirkton Road Centre. Ingrid was a lead author and John was the senior author. And that was sort of looking at transmission incidents of both HIV and Hep C in people who inject drugs attending KRC. It was pretty remarkable data, sort of looking back at it. The incidence of HIV was 0.2 per 100 person years, so less than a 1% risk per year. The incidence of Hep C was 20, so 200 times the incidence of HIV. And in people with less than 20 years of age, it was 75 per 100 person years. So that, I think, really sort of demonstrated that even though we'd had introduction of needle and syringe programs that had controlled HIV spread, amongst people who inject drugs for two reasons. One, because the sort of background sort of prevalence was already relatively high, and the infectiousness in a sort of blood-to-blood context, as far as injecting was concerned, was much higher for hep C than HIV, that it was going to be incredibly difficult to stop this epidemic. And there was rising rates of injecting drug use through the 90s. And then sort of some work led by Matthew Law in terms of modelling to project what was going to happen based on the incidence and prevalence of hep C and the numbers of cases of cirrhosis and liver cancer and liver failure that we'd see into the future. So then it became pretty clear that this was going to be a big issue. And as Alex said, we had very, very limited tools in terms of treating people at that stage.
Sione, what about from community perspective? When's hep C enter the radar?
Well, for me personally, it was in the mid-90s when I found out I had hep C. And I suppose I at that point in time, I wasn't thinking about it from a public health perspective, but I do vividly remember looking around and realizing that pretty well everyone I knew that injected drugs had this thing. And I think the thing that struck me is that no one was sick. And it's quite, as you can imagine, it's quite hard to kind of conceptualize having something that's supposedly infectious that might make you sick down the track, that at that point in time, there was no cure for. I vividly remember being told that you'll have that for the rest of your life. And so that, I also remember being told in the detox that I was negative for HIV and positive for hep C, and I had no idea what any of that meant. It was about 12 hours later that a nurse kind of explained it to me, but like I say, I do really remember that sense that everybody's got this, and it has a kind of a kind of a dual effect. Like, one is it's no big deal, everyone's got it, but on the other hand, it's kind of freaky that everyone's got it. And so on one hand, you put it to one side because you've got your day-to-day life to lead, and then on the other hand, it's this sort of unknown future that is, so pretty well everyone. I mean, when you're in your early 20s and injecting drugs, you don't necessarily think you're going to live that long anyway. You might not think about it exactly like that, but the odds are pretty low you're going to make it to this age. So at least that's how it felt then. So I think that I guess I suppose the words I have around this are for the harm reduction services that I visited and engaged with, and that did do a good job of us not having an HIV kind of epidemic in our small community, but also it was those services that told us about this thing, talked about how to not pass it on to someone else and all that sort of stuff. And I suppose the next time that it really struck me was when I started at Newer in the early 2000s. And started looking at some of the data and realized that, as my instinct that pretty well everyone had it was correct. And I think that at that point in time, as others have talked about, and we'll talk about soon, I'm sure that the treatments were not particularly, not something you necessarily wanted to do. And so the future still seemed pretty bleak at that point as well.
Yeah. And Kerry, from a policy perspective, when did the switch flick?
Well, I think there's sort of low levels. I think we need to remember when we discovered what it was, it then raised all the questions around nosocomial transmission, was gastroscopy, how was transmitted, whether there was mother-to-baby transmission, remember whether they needed, how did it align to the thinking around HIV, do you do Caesars, what's the risk, can you breastfeed? So for me in public health unit land, a lot of it was very practical issues that our clinicians were learning as well. And for many of them, we didn't have perfect answers because the work hadn't been done. I think, to be frank, the interferon-based treatments were never going to be able to be scaled, although I think Australia did really well that there was no bias around who got them, although there were some caveats around, at least being able to be off drugs for a certain period of time in the earlier phases, but more from a judgment of, is this the right thing for you at that time? I'm hoping that's how it was perceived. But I think, the advent of the new therapies really meant there was more of something that public health could get their teeth into. We were doing NSPs for HIV as well as Hep B, and I just really do accept that it was very hard to stop the transmission because of the characteristics, particularly for street-based injecting or more social injecting. It was very hard to do it. We would have transmissions even in our hospital settings with known infection control. So I think that was always very difficult to control. So for me, the opportunity arose particularly when we started to see the new therapies, and that probably was always a public health problem, but it really came to light when we had new tools, which was the therapies, which we could scale in terms of elimination.
Yeah, those therapies I remember being at a conference in 2014 or so saying these are on the horizon. So it took a while from the early mid-90s to get to there. And Greg, you mentioned you were recruited as a HIV man in Asia. And this is built and started as a HIV research centre. Was there a catalyst, a moment for hepatitis C to rise to that level of core interest?
For me personally, or
I guess more structurally, institutionally.
Look, I think from a personal perspective, there's so many people involved in HIV. It's very capable people, obviously. I mean, I always saw Hep C as an infection, as an infectious disease. I remember in the early 2000s, I think some of the gastros set me up to debate against a very prominent hepatologist whether Hep C was an infectious disease or a liver disease, thinking I was going to get so completely smashed. But I think sort of knowing that it was something that required a broader public health approach, even in those early sort of years, rather than a sort of a more narrower sort of clinical sort of liver disease approach, was something that made me understand that this is territory that I think will suit the Kirby. We had the sort of foundation of the epi and surveillance work that John had set up, I think, as a really important sort of basis to sort of then build upon. And a lot of the early work was in natural history, sort of actually showing that disease progression was slower than many people had imagined, looking at spontaneous clearance of the virus, looking at mother-to-child transmission and things like that. So, it was an area that was really, I think, sort of ripe for a public health approach and to build that sort of evidence. So, yeah, it was exciting to sort of get involved.
And one of the key pieces of evidence has been the National Needle and Syringe Program survey. So Sione and Ingrid, KRC, had a research program, but you're also part of that survey infrastructure as well. So can you talk about that long-term surveillance, that investment in that? What did it enable besides one-off studies that might come and go? What changed in terms of its being able to use that for policy influence?
So I think in the first instance, like I said, actually, that data was really important just to understand what's going on in the community. There are other things as well, but that measurement over time was a fantastic way for us to actually, from the community perspective, be able to talk to our community and first and foremost about what's going on. And there's always a sort of a mixed view amongst different community members around these sorts of things. And I think that the fact that it was part of the fact that this survey is part of this piece of work was part of the Needle and Syringe program, which is broadly trusted, I think, by people who inject drugs, was a really important part of the uptake. From a policy perspective, I think that for us, I think the things that we worked on specifically using that data at Newer and then later on in Canberra and Victoria and places I worked was being able to talk to politicians in particular, but other decision makers around things like peer distribution and secondary distribution and the importance of that. If we have this pool of infection and we have this number of people, and we've got these limited sort of NSPs with limited hours, it's really important for people to be able to pass on syringes. And as you would know, in different parts of the country, that's been illegal at different times because of the way the NSPs were set up. So having that data and being able to sort of really speak to the gravity of the situation meant that at different times we'd be able to sort of skirt around a lot of that a lot of the regulations that stopped us from doing things like secondary and peer distribution.
Yeah. And Ingrid, what about from KRC perspective?
So, yeah, we started, the service opened the doors in 87 and in fact was originally established as a recommendation to fill a gap in sexual health services for sex workers. By the time we opened the doors, though, HIV was already on the march, and so our funding came from HIV and we had a sort of expanded role. But yeah, we started with 2 full-time equivalent nurses, the same doctors, 2 reception staff, and 1 social worker. So we weren't really expecting to end up in a central role as far as surveillance or research was concerned. But as I mentioned before, we found ourselves right in the heart of it, in the heart of King's Cross. We were seeing a population that had not previously had great access to health services, with whom the rest of the health system was not in contact, who were clearly at very high risk and incredibly important to track. But yeah, as I said, we were a bunch of clinicians. So we needed to introduce a sort of a research culture into a clinical service. And that might sound really simple, but I'm here to tell you it's not. I'd have to say, it was people like John Caldor, Professor Michael Ross, who was based at the Albion, but I think was part of the original HIV social research area, came to one of our team meetings, and we already had a survey where we were in a fairly systematic way recording what risk behaviours people were engaged in. But they then were able to advise us further about that survey, how to collect these data in a way across time that was going to be more meaningful. And so that's really how it all started. And because we were in contact with people across time, it meant that not only could we be involved in the NSP survey on an annual basis, along with other NSPs right throughout the country, but we could also establish what we then called a dynamic longitudinal cohort, which enabled the incidence paper that Greg referred to. So we were able to actually not only know what the level of infection was at any one given moment, but also sort of track over time. So we became a sentinel site for the Kirby Institute for hepatitis C incidence in this high-risk population. We then, of course, as I mentioned, as referred to, we were involved right from the very beginning of establishing the NSP survey. I'd like to just take this opportunity also to acknowledge the late Margaret MacDonald, who was critical in establishing that, groundbreaking, internationally famous surveillance technique. Margaret had a history, a background in nursing. She was a great friend to Kirkton Road in every sense. And she also was very crucial in establishing a research capacity at Kirkton Road Centre, an in-house research capacity. So Margaret, literally went from nurse to counsellor to reception staff to talk about the importance of the work that we were doing, that it wasn't just about providing needles or doing the other clinical work that we were doing. It was also about informing the broader community about these key populations. So Margaret was very crucial in that. So yeah, we really took it on. It became very much part of the culture of Kirkton Road Centre. It informed and evaluated what we were doing, this sort of research. So it enabled us to improve our prevention efforts, as well as informing the broader Australian community about where things were going. But yeah, we discovered HIV, minimal. NSP was obviously fully effective for that. But hepatitis C, a runaway train, we needed to do a whole lot more for that than we clearly needed to raise coverage levels and so on. So yeah, that's just some of the important things that arose out of that.
Alex and Greg, I'm going to come to you about a treatment question. And Kerry's already mentioned that there were some differences of opinion in how hepatitis should be treated, and particularly what conditions might be put on people who wanted treatment in those early days, running against mainstream conventional wisdom, perhaps. So what research was needed to put person-centred care right in the centre of how to approach hep C treatment when we had still those brutal interferon-based treatments?
So as a young clinician researcher working in a hospital, we would treat people who came to the hospital. And if you didn't come to the hospital, you didn't get treatment. And we really didn't do any outreach. I think we started in 2014, 2015 to explore partnerships with the prisons in Victoria, still using interferon. I think we treated 10 people per year. That was the agreement we had with Justice Health in Victoria, that we could treat 10 people in a year.
Wow,
we
that's going to get to elimination.
So there were lots of challenges. I guess there was some skepticism. Well, there was a general feeling that the side effects of interferon treatment would mean that it would be poorly tolerated, and most people living with hepatitis C would not be candidates for it. And if they didn't come to the hospital, they would not be considered for treatment. Greg, you did a lot of research in this space, so perhaps I'll hand over to you.
So I sort of set up the St Vincent's Hepatitis Clinic in late '99. I think ribavirin was just about to be approved in combination with interferon. And the early data was that we could lift cure rates from a pretty abysmal 10% to sort of 35, 40%. So I thought now's the time to enter the sort of treatment space. At that stage, as has been mentioned, you had to be abstinent from drug use for 12 months. But we started treating people who were injecting from sort of the
civil
disobedience. But it was from a human rights perspective. And I mean, given that people who have other comorbidities or are injecting, potentially could have been much more susceptible to the side effects of interferon. Some people might have thought it was quite cavalier to do that. But obviously we discussed potential side effects with people and felt that there was a need to start to provide that access and start to break down some of the sort of dogma around who should be treated. I worked with Ingrid setting up the first hepatitis C clinic at KRC, I think in the early 2000s. Set up the clinic at Rankin Court Methadone Clinic, also in the early 2000s. So started to sort of broaden that sort of clinical sort of experience, I suppose, which was really important to understand different needs in different sort of settings. We started the first sort of GP pilot project of interferon treatment with Asham, again in the early sort of 2000s. So this is well before we had the sort of the DAs available. But it was an important sort of, again, an important foundation to lay for that time to demonstrate that you could treat people who others felt shouldn't be given the opportunity. And then John and I sort of set up the first Australian trial of acute hep C treatment through an NIH-funded grant that we received in 2003 because the US thought that Australia could do this, could actually demonstrate that you could treat people who injected drugs in an acute hep C sort of context, which might seem even more sort of difficult given sort of recent sort of risk behaviour. So they were really sort of important times. I mean, we collaborated very closely with Margaret Hellard at the Burnett on that study. There was members of the hepatology community involved in that early sort of study, Jeff McCorn and Bill Sievert, Bill Rawlinson, in terms of the sort of testing laboratory-based work that we needed undertaken. So it launched, I think, real leadership from the Australian sort of context in the space. And I think that was, I think, if we think about where we've been, we've had leadership, not just in that area, but leadership in many fronts, leadership in a public health sense, leadership in a governmental sense, leadership in a social research sense, leadership in a community organisation sort of sense. So I think there are many sort of aspects to that response that were really sort of pivotal in those early years, well before we've had these sort of transformative sort of therapies arrive.
Yeah, Sione, I'm going to start with you for the next one, which is about working with community. So my notes have a very nice thing saying, people who inject drugs are a population long overlooked by mainstream medicine. I think that's very gentle to say, subject to dogma, exclusion, discrimination, exceptionally poor treatment. What did it take to build some genuine relationships of trust to work with researchers, research clinicians, and come to care about, working in a government and policy role as well? What happened?
I mean, I guess briefly, I think that some of my predecessors in places like Newer and Vives or HRVIC had been working with sort of individual researchers, and Greg's got a book there with a chapter by Jenny Kelsall, who was the previous CEO at HRVIC, and with Michael Kruger, I think, and that was from the late 90s potentially. So sort of individual relationships like that I think were really important, and those things moving forwards also were. So I think there's a general distrust amongst community and people who use drugs for the government broadly, and then all of the institutions that we talk about are often like piled in there as being sort of as being something to be distrusted. So I think that organisations like Newer, like Harm Reduction Victoria, like the other community organisations that have been working with researchers are key for building sort of individual but also structural relationships. And then it becomes essentially trying not to be screwed over unintentionally, usually. And so I think that I genuinely think that seeing things like Greg was talking about, like when I first started in this work, it was really, I was very cautious about whether or not to trust what was going on, because we'd seen things sort of offered and then whipped away, if that makes sense, over time. There's lots of different examples of that. I mean, to this day, so many projects are still research pilots essentially, and even though researchers don't intend to whip them away, when they end, the money goes away, the program ends, and there's it's often the community that end up no longer being served. So little by little, brick by brick, really, with little project by little project. And I was looking back on some of the stuff that I was initially involved in with Greg and Jason and others at the Kirby, including things like the Ethos project, where I remember I was working on it, but we had other peer educators peer workers working in the pharmacotherapy clinic. And I remember going down and visiting and talking to them and the nurses and everyone and the clients as well. In fact, at a clinic that I was a patient at, and the patients were just so surprised this thing was happening, because it had been something so distant, like as Alex said, it was in hospitals and stuff, and now it's happening in this clinic. I think one other thing I'd add, and not to glaze them too much, but I was talking to Jason earlier about essentially community being invited to conferences, including overseas, to talk about their experiences in partnership with researchers. And I think those things slowly over time have helped.
Kerry, what about getting government support to work closely with community agencies, community members? What kind of work needed to go on behind the scenes to educate the structures and the powers that be that this was really important?
Well, look, I've been in a sort of leadership role for a long time, and there's certainly, I just want to acknowledge ex-Minister Skinner's in the office, and clearly when Minister Skinner's Chief of Staff came in, both the combination of those came in with a reform agenda for HIV, and to just acknowledge Bill Whittaker, the late Bill Whittaker, who was a friend and colleague of who I learnt so much from as a person, as a human being. And I think that authorising environment was actually really good to change things and reflect and to challenge. And I think probably that facilitated in the HIV sector some even more robust conversations. And I talk often about the fact that we need the ministry to be strong, or the department policy people to be strong. We need the patients and affected communities to be a strong voice, and with HIV we clearly had that as well. And we also need the academic researchers, and it's only when you've got each of those in tension, but happy to listen to each other. You don't always have to agree. I was in many issues when we were trying to sell things to GPs and clinicians that they weren't having, until with David Cooper in those, with the HIV treatment as prevention sort of component. My God, that was hard until that study came out that showed individual benefit. So I think understanding shared perspectives, and the more we can listen to each other and have that sustainable lens, that government has got to be committed that it's safe, sustainable, cost effective, and that we actually can do amazing things in government in terms of, authorised nurses to do things. We know our way around our poisons in structures and stuff like that. So the more we can work together. So for us, there will always be a moment of an authorising environment where government is prepared to focus on conditions. That will be different at every government. Every minister will have their own priorities. There will be different contexts and structures. But I think what behind the scenes is we can continue to work, and I hope that from the New South Wales Health perspective that we're there to listen, learn, and also, continue to have a contest of ideas. And that's going to be really important for us to do that. But I really see the community voice, what's acceptable, what will actually work, and particularly for our communities, a more holistic response. I'm also tempted to think about sometimes why we silo from a Hep C perspective as opposed to, around your treatment goals or access to other services which will ensure an outcome as well. So when I'm talking to my drug and alcohol services, I'm talking about Hep C treatment, but I'm also talking about general physical and mental health linkages to other services. And so we probably have to do that negotiation about when you might want to do a Hep C specific initiative, but I might actually, in partnership with communities, say, well, we actually want a wellness initiative, and that's got different elements. And so I think that's a challenge for us as we go forward. How do we ensure that we're improving the health of the communities that we want to serve?
Greg, you want to jump in?
Yeah, just a quick reflection, just in terms of the two-way sort of direction of learning with the community, and we've learned an enormous amount from the community. We've been very fortunate in Australia to have the community leaders of the stature of Annie Madden and Jude Byrne, and I remember being on a seminar where I sort of floated the idea, this is before the DA era, floated the idea of treatments prevention, and having a very robust discussion with Jude and Annie about vectors and not being seen in that sort of context when we're talking about population level sort of approaches. So yeah, I mean, those conversations and many chats in corridors along the way have been really important, I think, to understand the context of the work that you do.
So just let everyone know, we've got about 2 more topics to go through, and then we're going to open it up. So I've just asked for help turning on the Slido because I can't do it. But Greg and Alex, about clinical trials, major international clinical trials that you've been involved with. Greg, can you start and tell us a bit about how they came about and what the Kirby was doing in there, besides just trying to do good? What was it all about?
Yeah, it's interesting when you think about we've sort of themed the symposium local action to international impact, that we talked about starting locally in terms of providing services, and then we set up a national sort of network for the acute Hep C trial that was funded by NIH, and then we needed to go international. I think it was time to really sort of take things to the next sort of level and provide sort of leadership, particularly in clinical trials, addressing treatment safety and efficacy in people who injected drugs. There'd been some really good people doing some great work in different sort of areas, but not really with the sort of operational excellence, and we'd certainly developed that in our program. We had Bit Marks, who was a real sort of champion in that sort of space, driving things forward operationally. And it gave us a capacity to sort of really launch things internationally and collaborating with some great people all across the sort of globe. And people were really, I think, thirsty for involvement in those sorts of trials and to have an institute that could provide that sort of leadership in terms of setting up really pivotal studies.
Alex, did you want to add anything?
I guess I'd make a comment about industry-led clinical trials. Australia, before we knew what hepatitis C genotypes were, Australia has a high prevalence of genotype 3 than many other parts of the world. So Australians responded better to interferon because there's more genotype 3 here. So I think Australia was a popular site for interferon companies to run clinical trials, and that really created an environment, permissive environment for clinical trials. And then over time, I think Australia has managed that interface between academic clinical trialists and industry-led clinical trials and the relationship with pharmaceutical industry well. And I think Kirby has really led in that space. Perhaps, I mean, I imagine there's a lot of, I'm not an HIV doctor, but I imagine there were a lot of HIV clinical trials in that space. But I think in hepatitis C, that's been done very well, both in terms of refining clinical regimens, phase 4 studies, shorter duration, different doses. But then in the DAA area, partnerships looking at taking treatment outside the hospital into prisons, into the affected populations. And that's really made a big international contribution.
Yeah. So to round out this conversation as we're focusing on elimination before we get to some really juicy questions, what's left to do as we're racing towards 2030 elimination? What haven't we paid most attention to? What's still to be done? Ingrid or Kerry?
We've still got a lot of people that are left behind. We've got to be attentive about our Aboriginal population, which is overly represented in incarceration, still has a high burden. So for me, it's probably we're going to have to invest per unit person a lot more in those wraparound services and other social supports to support them engage with care and get access to treatment. And I think for us, it's really, can we actually, I think we've set a KPI for justice, and I think Minister, you're on the board, so please ask Wendy about this. I think we came down to 80% of all, was it Chris, 80%, or we started with 90, but we went down to 80 for the first year. But 80% of all people, including those on remand, will get a dry blood spot as part of their KPIs for their service agreements for next year. And let's just see how many of those we can then monitor time for test return, and we need pathology to get those turnaround times done. And there's a few issues of specimens going across different labs, but then tracking how many of those we get treated in facility and how many, get to completion, so learning. So researchers, great NH&MRC partnership grants or NH&MRC grants to really look at scale if we can do that and learn about connective to care. And I think a really important learnings from community about what will work for people. So that's our challenge for this year.
Sione, what are you, in your minds left to do?
A couple of things, I suppose. What we're seeing is, or thinking about at Harm Reduction Victoria, especially, but I think it's pretty countrywide, nationwide. Is there's a lot of social isolation. There are a lot of older people, whether they still inject drugs or not, who haven't availed themselves of the treatment, haven't known about it, haven't been able to access it, haven't wanted to. There's a plethora of reasons, and as we sort of get through, the bulk of people, these people are genuinely isolated in different areas, and it's very tricky to engage with them. I think that obviously peers have got a really important part to play in that, but it will be time consuming and possibly resource intensive if that's what we want to do, if we want to get it right down. And the other thing is that as we're seeing reinfection is playing a part, it exists. I think that it just reinforces the prevention. Harm reduction is still really super duper important. And we can't take our eye off that ball.
What do you want to do, Greg? What's left?
I think keep innovating. I think Australia has been incredibly good at providing innovative solutions. And I think it's not just what's required in the Australian context, it's what's required in the global context, because most countries are way, way behind in terms of how they're tracking to elimination. So we've got a trial that Marion Martinello is leading, looking at a 4-week treatment duration strategy that we hope to get NHMRC sort of funding following our pilot data to evaluate. So that's really exciting. There's the potential maybe for long-acting injectable sort of therapy, which could be incredibly important for different groups. And there's, as I said, just there's a 2030 sort of like goalpost, so to speak. But there's going to be a lot more work to be done beyond 2030, and this sort of notion that, okay, we get to 2030 and then pull up stumps. That's certainly not going to be the case. So yeah, I think just keeping that sort of optimism and the thirst for innovation are really important.
Alex?
There's many important points that have been made. I think maintaining the rage is really important at the moment. I think it's just more work to find people with hepatitis C now, because there are less people with hepatitis C. They're often more marginalised, so it's more resource intensive. And I think that can be, well, policymakers can step back because it's more expensive, but also the staff on the ground can disengage a bit as well, because there's less hepatitis C people they're finding. So I think it's really important we continue to be supportive and continue to encourage and continue to focus on the hepatitis C programs. And then globally, we really do need a vaccine. The vaccine would make a big difference in Australia, but globally we need a vaccine to eliminate hepatitis C.
Ingrid?
Mine's really simple, drug law reform. As long as drug use continues to be a criminalising behaviour, people affected by hepatitis C and a range of other health issues will continue to be discriminated against and stigmatised, and that will always be a barrier to good care. So if we could just get that sorted out.
By the end of the year, I'm sure, be no problem. So there's a couple of questions that tie into some of the themes. So, from Andrew Grulich, treatment takes only 8 to 12 weeks or maybe 4 weeks. Can we reach elimination without a vaccine? And how far away are we from a vaccine?
I think we're a long way away from a vaccine. There are some vaccine experts in the audience. I'm not qualified to comment, but the vaccine studies to date have been very disappointing. And I think the success of treatment has been a distraction from vaccine development. It's become less attractive to the pharmaceutical industry, but we really need a vaccine.
Can we get to elimination without one? Yes, from Kerry? In Australia, we can. Okay. Vote of confidence? Any dissenters?
No, look, we'll get to elimination on the incidence front. We'll meet the WHO target of less than 2 per 100 person years, I think, in people who inject drugs, and less than 5 per 100,000 population. I think we'll achieve those targets. But what we've got to be careful of is that Hep C is a very transmissible virus. So if we pat ourselves on the back in 2030 that we've achieved the target, then start to dismantle sort of the public health approaches, it's going to take off again. So I think that's really important to understand, that it's not going to be completely eliminated. So we'll need to be vigilant.
So a question from Anonymous about the origins of Hep C. Why wasn't it discovered until the 90s? Was it always there? Did the HIV spotlight help people understand, discover, give it its own letter?
I think it was there for decades, wasn't it? I think they went back to blood samples that had been taken, was it the 1940s or something, among military recruits in the US, and the prevalence was already quite significant. So it had been around for a while.
Centuries. Yeah.
Centuries. Well, given that we're going to achieve drug law reform by the end of the year, what can we do about getting NSPs in prisons? It seems ridiculous to keep treating and retreating people who acquire hepatitis C in prison. Why can't we, and how do we, get NSP in prisons?
Well, having been in Canberra when it failed, I think it's going to be a multifactorial thing. We might not ever get there, but I think that what I do know is the prison officers have to somehow be dragged along. Yeah, it shouldn't be complex, but it is. And drug law reform, somehow dealing with stigma and discrimination on a higher level, educate, all those things are probably, would have an influence, but I'm very pessimistic about it, to be really honest with you.
It's interesting, when we did the Stop C trial, which is a treatment trial in prison in New South Wales, I remember going to Goulburn Jail and presenting at the monthly prison officers meeting and about the project we're going to do, and meeting some pretty vocal resistance about why we were sort of putting this effort into Hep C. But sort of thinking on my feet, I sort of tried to sort of switch things around to sort of occupational health and safety and saying, look, if we could sort of remove Hep C from the setting, that they would be at sort of reduced risk in their occupation. So there just seemed to be a psychological block around Hep C, and I think that's part of the problem in terms of introduction of an intervention that is broadly implemented in the community sort of sector. So how we overcome that psychological sort of block, maybe it's part of the workplace contracts, and maybe it's inducements, so to speak, in terms of supposedly taking on some additional sort of risk that might be entailed. But it has to be working with the prison officers and the unions, otherwise it's not going to get through.
Look, that is for government, a decision of government, and I think you've identified some of the barriers, but not all of the barriers that are there, and it's probably enough for a broader discussion. But I do really want to say that if we actually can get everyone tested, like using the tools, like we should also focus on the tools we have available. And I am so passionate about making sure everyone is tested immediately on remand. If we can get the turnaround times for our dried blood spot tests down to a week, and then get people immediately initiated on treatment, then we'll rapidly drop the pool of infection in the population. It may not, I agree with everything that we need multiple interventions, but I'm just saying that is an opportunity. So everyone should be driving at least, let's give that a red hot shot. I just want to acknowledge the fact that the team across, Bill Rawlinson's group and the prisons, and a big call out to a public health officer, Jenny Heslop, who personally wrangled a jail to do it. But with minimal money, we managed to get a validated assay with TGA, and and a few more grey hairs, I think, to Bill for the repeated questions. But that just goes to show we can innovate. Let's give it a red hot shot. And even if it fails, then that's even more argument. We've got to do something differently. So let's give it a red hot shot.
Thanks, Kevin, for that very juicy question. So as we're getting close to the end of our time, a couple of questions focus on what Australia should be doing, given our success, to support our neighbours in the region for their hepatitis C responses. What do you think? What's our role? What's our responsibilities to support our neighbours in the Indo-Pacific?
I'll be really brief. Without being colonial about it, to be really frank, which happens. I have Pacific heritage, and it's a very real thing still. There's a lot, but I think that, from my perspective, supporting wherever possible peer networks, and I think that the organisations in Australia have a responsibility to try and enable and support peer networks in different parts of the Pacific, which is happening, but it's incredibly disappointing that they're not supported through. That's not supported through resourcing very, very often or at all.
Yeah, I think the HIV issues in Fiji is a really pertinent lesson there. Anyone else want to talk internationally?
It's just a small sort of project that we're starting to develop with colleagues in Cambodia. I've been working with Miriam Levy on a project looking at screening people attending emergency departments and evaluating leakage to care of those that are shown to be positive for infection. So the plan is to adapt that model, work with colleagues in Cambodia, and apply it both in terms of important surveillance-based data in terms of prevalence, and also to evaluate whether we can sort of link people to effective care. And there's a few barriers to overcome in terms of getting access to the AAs that are not broadly government funded in settings like Cambodia. Yep.
Right. Well, we're just about at time, so please thank our wonderful panel, and I'll hand over to Greg.
And I'm going to thank Carla for an amazing job of chairing, and I'm going to hand over to Greg for a vote of thanks. But before doing so, just to to revisit those crucial episodes in Australia history and public health history, and from the people who were right at the front line. But then also to think that the trial that Greg mentioned, where the US funded a trial in Australia of treatment for people who inject drugs, we've sort of, there's a few steps backwards that we have to be dealing with. And I think that Alex's comment about keep up the rage is obviously going to be crucial. So over to you, Greg, to wrap up.
Thanks very much, John. Firstly, I'd like to thank Sam and the team for the organisation of the event. It really takes a lot of work to sort of put these together, and really appreciate your support. Thanks everyone for coming, but I'd like to really acknowledge some other people that haven't been sort of mentioned. I think the Kirby has played an incredible sort of leadership role in this space, and there's some people at the Kirby, either past or present, that have really provided that sort of leadership both nationally and internationally. I'd really like to acknowledge Gail Matthews' sort of work. Gail came to work with us in the early 2000s, did a PhD, in fact, in hepatitis B with HIV co-infection, got involved in the acute hep C work, and then took that over and really led, including the first sort of randomised control trial that was our third sort of NIH grant that we had in that sort of space, and has been a true sort of international leader. Also like to acknowledge Andrew Lloyd's sort of work in the prison sort of sector, setting up the nurse-led model of care, and how important that was to demonstrate that you could take treatment out of the hands of the specialists, and all those barriers that specialists can put in front of sort of broad-based sort of care, and really has been an international sort of champion in that space. And as has been mentioned already, but Jason Grebley, who's really been an amazing international leader, not just in research, but also in sort of policy, and his sort of presidency and leadership through the INSU organisation is another example of Australian sort of based sort of leadership. So yeah, some really important people to acknowledge. So thanks everyone for coming, and I hope you really enjoyed the afternoon. And there's some refreshments outside.